patient scenarios for risk stratification. All cardiac patients present to you basically the asymptomatic patient. This will be actually the most difficult and sometimes maybe the easy one, but can be the most difficult to diagnose and so on. Then you have the symptomatic patient with no cardiac event prior who comes to you with shortness of breath or chest pain, whatever symptoms. Then you have patients with a cardiac event, ACS or STEMI. These are more clear cut. You know what to do. Most of the time you jump in and do invasive procedures for them. And of course, we have the pre-op evaluation. I'm not going to talk about scenario 3 and 4 today, but more towards 1 and 2, and in regards to scenario 2. So how do you risk stratify? There are a plethora of tests, what to do, and it all depends on the type of patient I mentioned, the 4 scenarios. What is the pre-test probability? Most of it actually hinges on uh, the statistical prospect of this patient having heart disease. Sometimes it's not easy, and at different times in their lifetime it can be different. So somebody who's negative now for some tests, maybe 12 months down the line can be positive. And then you have to know what are the tests available, the testing pros and cons. So basically this boils down to resources. What is the practicality, the availability? Do you have a dobutamine stress echo, cardiac CT if you want to go to the next step, even an angiogram? What are the safety parameters of the test? How safe is it for the patient? And ultimately, the cost and the logistics of it. But most people forget, no matter what you do, patient preference is very important and paramount. Because if they do not agree, if they do not consent, you cannot do any test. And the other thing, people get carried away, doing dobutamine stress echo, cardiac CTs, and so on. Before you proceed, even with a simple test, you must ask the patient what do they want. If they tell you from the onset they just want medication, that's all, and they're not going to, agree for any invasive tests, any like bypass, PCI, if they have, triple vessel disease and so on, what is the point of, wasting resources, putting the patient to high risk just to find out he has triple vessel, but the patient want nothing to be done. So that part is very important. So again, patient scenarios, I will consider number 1 and 2. And when you look at coronary artery disease, ischemic heart disease, it's a spectrum. So you have all the way from normal function right down to the end stage where you got infarction and scar. So along this spectrum, the patient can present to you anytime. And sometimes they can present earlier. The problem is when they are actually at the early stages, some of our tests has a lot of limitations. They cannot detect the perfusion abnormalities, diastolic abnormalities, and so on until the patient has profound ischemia. So most of the time we actually get patients right on top of the spectrum here once they develop angina, and worse still if they have a myocardial infarction. So every test depends on the sensitivity and specificity. In a nutshell, sensitivity means the percentage of patients with a disease who will have an abnormal test. And again, important, the specificity, where the patient will be free of the disease will have a normal test. So you can never have both both worlds. The ideal test, you have high sensitivity and specificity, I'll show you it does not exist. We are trying what we can, but at the end of the day, it is a combination of tests, and you have to put that on the table. So what do the guidelines say? This is the American, stable ischemic heart disease guidelines. So basically it hinges on the fact that the patient is able to exercise or not, and you go along that to see the plethora test. But when you come to the NICE guidelines from the UK in 2010, they look at the pre-test probability. What is the possibility? A 20-year-old lady having chest pain is different from a 70-year-old gentleman having chest pain. So you have to factor that in. So our guidelines in 2018 is actually like a hybrid of both. So what they've done is we do not have our own data, but we are hinging on the European data. So basically, when you have somebody presenting with chest pain who are stable with the clinic, we look at the pre-test probability. So if it's anything between 15% to 85% intermediate, then we will actually go and see whether they can actually exercise, and will go along doing the test. If they're below 15%, the young ladies and so on, then we can actually tell them that, look here, most probably you do not have to do anything. But most Malaysians have at least diabetes, dyslipidemia, hypertension. So those immediately become into the intermediate category. More than 85%, you can actually elect straight away to jump to the more invasive tests. But there are caveats. So this is the simple chart for pre-test probability. But if you look at this, those above 70 and men with chest pain straight away go into the red zone, and the rest of all the men go into the yellow zone. And very few you can actually talk about low test probability, the green zones, especially ladies, even up to 50 years old, if they have no pain, incidental finding or ECG changes, you can elect to do that. But it's a double-edged sword. I can tell you there are, patients, especially I see a lot of my Indian ladies who have chest pain at 50 years old and been treated with, Imdo, Wastarel, 7, 8 medications, thinking they have coronary artery disease. And when we do cardiac CT, or even to the extent of angiogram for those who have recurrent admissions, we find they have normal coronary arteries. So that is the other side of the coin. You overtreat them, and then all these medications come with side effects. And the other thing is, the patients sometimes get upset, saying that all the while they have been conditioned to think they got triple vessel disease, when they find they're actually quite normal. So that is another challenging thing you have to think about. So it is always fine balance when you do this. And when you talk about pre-test probability, although we are using the European score, you can actually get this in your smartphone. The Diamond Forrester pre-test probability is there, and you can actually calculate whether your patient is intermediate or not, and then proceed from there. And this is a simple one. You can get it on any phone. And so coming back to your cardiac investigations, the most basic, which actually you don't need any guidelines to tell you, is an ECG. Okay, but at the same time, ECG can be the most deceptive because it's resting ECG. Then you have stress test, echocardiogram, nuclear perfusion, cardiac MRI. These are functional. Okay, when you talk about tests, they are functional and anatomical. Anatomical is cardiac CT, coronary angiogram, which is more invasive. MRI plays both parts. It can be functional, it can be anatomical. Okay, so sometimes you need a functional test most of the time to evaluate them before you go to anatomical. But there's now a lot of data saying that maybe you can jump to cardiac CT for certain group of patients. So when you come to functional tests, don't get confused. People always think that, oh, ECG, echo, then there's stress echo, then you might do exercise stress echo, dobutamine stress echo, nuclear stress, cardiac. So it's very simple. One modality on the left is how you evaluate the patient: ECG, echo, nuclear, cardiac MRI. So all these tests you can actually do a functional test in two ways. Of course, you need a rest. You always need a resting test as a baseline, and then you put the stressor. So the stressor can be treadmill exercise, bicycle exercise, can be non-pharmacological or pharmacological. You're talking about inotropes like dobutamine. You're talking about vasodilators like diprodamol, adenosine. And you can couple this with, for example, dobutamine with echo becomes dobutamine stress echo. Dobutamine nuclear becomes dobutamine stress nuclear. Dobutamine MRI becomes, so, you can do that. We also do dobutamine with ECG. But most of the time, the commonly available test is your friendly treadmill exercise stress test. But keep your minds open. So this is how you stress a patient, because most of the time, sometimes ischemia is not present at rest. If present at rest, most of the time they're already having an event. So you have exercise stress, non-exercise stress. So there will be differences between both, but the common one we usually look at is treadmill exercise stress test. So I'll concentrate a bit more on this test. But before you jump to the test, you must know how sensitive, how specific they are. So as I told you, ECG stress test is not so sensitive, maybe 50 to 70%. Even specificity, at the most, if you ask me, is 80%. Stress echo can reach 90-95%. And if you go for MRI, you can even go 90-95%. So if you look at all this, you realize there's nothing in life which is 100%. Okay, and the very patient who is negative stress test now, you know, the chances of him having an attack is never zero. You still can have an attack, but less than 1% at 1 year. And 2 years from now, it could be different. And this is your annual mortality. You look at your stress test. If your negative stress test is never zero, at the lowest, it is less than 1%. So negative stress echo is never zero. So you can never tell a patient, it's always a statistic probability that nothing will happen to you. Basically, we are best guessing depending on the data we are presented with, the current level of evidence, but patients are patients. So those with even negative stress tests, a lot of risk factors, you have to keep an open mind and also tell the patient that he's cured of this disease. You can still have coronary artery disease later. And so there's a continuing spectrum. Thank you. And then the same thing goes for stress CMR and coronary angio, sorry, CT coronary angio. So absence of any plaque, anything bad happening within 1 year is less than 0.25% is low. Okay, but doesn't mean it's zero. So I will concentrate a bit more on ECG stress test. I think it's available most of the places. So exercise stress test is the non-invasive test of choice in patients who can exercise, okay, and have interpretable ECGs. So you have to be very clear on that. It is a safe test. Is anything bad happening is 1 in 10,000, but as I mentioned, it's never zero. So if your stress test is negative, there's an intermediate to high probability of CAD. So your pre-test probability is more than 65%. So somebody who has, diabetes, hypertension, dyslipidemia, you might consider re-evaluating him for further, especially if it's symptomatic. If there's low probability of CAD, if your stress test is negative, usually I will tell them it is negative for significant ischemia at high workload. You should look at the pre-test probability. If he has diabetes, hypertension, I will mention that. I won't say you are negative for coronary artery disease, because you do not know they got 20%, 30% coronary artery disease. Only that you don't have significant obstructive coronary artery disease. If the EST is positive at low workload, then it is a no-brainer. Basically, you need to go for a more definitive. Most of the time, it's an invasive coronary angiogram. So even before doing a stress test, ask the patient, is he keen for intervention and so on. If the patient is not keen at all and he tells you upfront, you don't even have to proceed further, just continue medication, and then you base on the symptoms and so on. Okay, at moderate to high workload, if your stress is positive, some of them are positive at stage 3, stage 4, especially those who are athletes and so on. Then you can actually discuss with the patient what to do next. Most of the time, it will be just medical treatment, okay? But sometimes you can actually consider CT angiogram, something less invasive, unless the patient strongly feels he wants an invasive test, especially those with very strong family history and so on. So next comes in functional tests, stress imaging tests. So basically, these are used for individuals who can't exercise, or they have ECG changes which preclude interpretation, like left bundle branch block, WPW, your digoxin, and so on. Or stress test is equivocal. Those with we say inconclusive stress test, then you have to proceed further. So this is a common protocol, Bruce protocol. We have modified Bruce for those who walk more slowly and things like that, elderly patients. And you have other protocols which you hardly use, McConnets and so on. And there are contraindications to exercise stress testing. I won't go into detail, but anybody who's having active ischemia, chest pain, obviously you do not want to do a stress test. And those which ECG interpretations will be difficult, you might not want to do a stress test. So when do you stop a stress test? Most of the time, if the patient has achieved his endpoint, where the target heart rate, well, in modified Bruce, you can go for 85%. I'll usually push it to 90%, 95%, depends. So if they actually fulfill this criteria, or the ECG changes, or the patient wants to stop, you actually terminate the stress test. And basically, you look at three things: electro ECG, hemodynamics, and symptomatic. Most of us only concentrate on the ECG part of it, which is actually not the proper way of assessing a stress test, because you need to calculate the STS or the Duke score if possible. So ECG is quite straightforward. One of it is the maximum ST depression, but the other things, you can have ST elevation, you have ventricular tachycardia. There are other things you can actually look at, but most of the time we just look at this important parameter. And then comes to hemodynamics, whether there's a drop in blood pressure, whether the heart rate is not achieved, and things like it can be actually signs of ischemia, and total exercise duration, and whether they have symptoms. Symptoms are important. If you have chest pain in stage 2, even without ECG changes, it can be interpreted as positive. But the difficulty comes when they have shortness of breath, when they have, decreased effort tolerance, they cannot go on. You're not sure whether it's angina equivalent or what, so that's important. So a positive stress test, basically, this is just the ECG criteria. So you can define it as ST depression more than 1 millimeter horizontal downsloping. The specificity is still just 80%. So the last two, horizontal or downward sloping, okay? But you must look at other things, the patient himself, whether or self, they're having chest pain, whether there was a drop in blood pressure, the other things you have to look at. And this is the DTS score. You can get it even from your smartphone and things like that. But most of us don't take the trouble to calculate, but this is quite specific in a sense, so Duke Treadmill score, but of course not as high as the stress echoes and MRIs and nuclear perfusion scan. So this is one way of manually calculating this Duke score. So you can have problems when you got especially left bundle branch block. Right bundle branch block, you can still do the stress test, but there's certain areas you might not be able to interpret. But lateral branch block is a no-no for stress test, and it is also a no-no for stress echo. WT means stress echo or whatever stress echo, because you have wall motion abnormalities with left bundle branch block you cannot interpret. So basically, you will need either a nuclear perfusion scan or even anatomical tests like cardiac CT and so on. And women can be a special group. They have a higher rate of false positive stress test. So once a person is false positive, and how we know is, sometimes we get referred, these are cases, the angiogram is normal, they will always be false positive with the stress test. So if you want to do next time, do not repeat stress test, but you might need to do a stress echo, nuclear perfusion, cardiac MRI, or something else. But do not repeat stress test repeatedly, because it will be positive lifelong. So now coming to stress echo, we covered your stress ECG, but stress echo, the thing is, you can look at diagnosis, prognosis, and also viability. So these are those patients with already perivascular disease, poor EF, what they do. So there are a lot more things you can look at. You look at 17 segments in your original wall motion. So again, you can either give exercise, treadmill, and you do, or you can give non-exercise pharmacological. The most favorite agent is dobutamine, and this is your standard format. You have the top left hand corner, rest, then you have low dose, peak dose, and then you'll have recovery. So we will look at the regional motion in at least 4 or 5 windows in these settings. So these are the pharmacological stress agents we use, either inotropic agents or coronary vasculitis, and we can also use a wall motion score index. So if you have 3 or more regional wall motion, then it is significant ischemia. If you have less than that, you can just say you can just go for medical treatment. And this is how we interpret our stress echo. You can have a normal rest, hyperkinetic stress, so it's normal. You have a normal rest, at stress, it goes hyperkinetic, it denotes ischemia. If you have akinetic to start off and is akinetic throughout, the muscle is dead. It's just medical treatment, it's infarcted. If you have akinetic to start off and it becomes normal and then it goes by akinetic, that means the muscle is still viable and you might able to restore the function if you were to open the artery. So this is what we do. So nuclear perfusion test is only available in select centers. Even in Sedang, we do not have it. So basically, they require introduction of radionuclide substances, basically thallium-201 or technetium-99, as it moves through the venous system. So they look at the ejection fraction, wall motion abnormalities, blood distribution, and so on. So you have the same data you get from stress echoes. Some people say